Maybe 5, 4, 3, 2, 1.
Janki?
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have Professor Ananda Kishor Pal sir from IPGMR Kolkata. So he's teaching us about how to you prepare for practical examination in orthopedics for your MS and DNB and diploma examination. So over to you, sir.
Thank you, Janki, for your kind introduction. Is my slide is visible?
Yes.
Just okay.
But you're on your thank you slide, not in the beginning.
Okay, just I'm coming. Okay. So good evening, everybody. It is a special class for my beloved students. So this is especially dedicated to them because this is a very, very important class for preparation of the practical orthopedic examination. Basically, the practical examination in orthopedics, basically, it is a test of psychomotor skill and affective skill. Psychomotor skill is how much the candidate or the student has become trained about regarding the deliberation or the in handouts and to application of their knowledge. Because knowledge part is on the cognitive domain, whereas in the especially the examination part is in the psychomotor domain, is the hand-on test. Another is the affective test. That is, it is now coming in a very big way. So how much the candidates or students become very much expert of dealing with the patient, either their parents, their relatives, to break out the bad news, to counsel the patients, and to how they interact with the patients and the relative. This is also important, and this is the affective domain. Now there are two types of examination is going on. There's one in one short. There is some clinical case, like long case, one's long case, and 3 short cases. And in long case, there are some the inclusion of the surgical and the operation. This is the classic. This is the left side is the classical operation, classical examination view. And in the second part is the oral and viva voce, where there are 4 tables, of which the specimen osteology is one, radiology flying oral is the second, orthotics, prosthetics, research, design advances and thesis is the third, and the last one is the instrument of the operation. Whereas it is the another classical, another modern examination, it is coming in this way on the right side, where it is based on the OSCE system, where there are some specific the clinical problems is given, and there are some specific answer is asked for within a time span. This is extremely very formative, and then candidates should be extremely cautious to answer this. This is the OSCE system. This is one part. Another part is the case one. This is it may be real case, or it may be virtual case, of which 50 marks will be there. The second one is the either real or the virtual case. So either in most of the situation where there is one real case and one virtual case is given, and the specific set of and questions is already there, and this is specific set is asked for the specific candidate within a specific time period. And lastly, the oral and viva voce is almost same, but except this one, there are 4 word round. This is extremely important because this set of examiners, they are very much concerned about the practical experiences, whether the knowledge is deliberated during the word. So there are 4 word round. That is a 4 into 10. That is 40 marks. This is extremely important. Apart from that, there are 4 stations, especially on this viva oral and viva voce, as is the classical examination pattern, and there is only 60 marks. So this is the modern examination. I think all of you understand which examination I want to mean. Now the OSCE. Now, basically, the OSCE, this is basically, you have to be very much cautious about, because there are specific answer is asked about. So we remind the time span, we have to notice the marks given in each questions. We have to observe the picture or the video and analyze within the short period of time, and we have to point answer, and then mind it, there are maximum number will be 6 or 10. Now, there are virtual cases or the real cases. In all the cases, as the time span is very short, there are some information should be already mentioned, some information should be asked for. Like information mentioned is there is some background of the case or short list is already given. Already it is mentioned in the PowerPoint form, and there may be video of gait or there is some picture showing any part showing some specific deformity or sign, or there's some video, some test will be given, and you have asked to tell which sort of test is given for, and also mention, also mind it, there's some time allotted and with the number. So information asked is, suppose there is a background is given, then next question will be what the probable diagnosis, what are the differential diagnosis. Next, the identification of the gait. Suppose it's a video of gait. Now we have asked, you have asked about the identification of gait with explanations. If there's a picture of the any part showing specific deformity, you have asked about the identification of a specific clinical test with explanations. Similarly, if some test is given, if already you have to identify the test, and then from the overall, if we asked about the relevant investigations and the management. Now, if there is a real case, already again, because of the shortage of time, you have given already, you have some history is already taken, and you have provided that short background of the history. So you need not take the history. And you can ask some specific history. That is, if there any specific history is lacking, you can ask some. You have to ask, do you want to get any other history or not? Now you can ask. So this is the cognitive domain. Now, if there is specific clinical problems already given, you may be asked about the specific clinical examination. That is a psychomotor domain, or there's some problem. You have to provisional diagnosis or differential diagnosis. This is the cognitive domain, and some relevant investigations or management or the counseling. It is most important. Sometimes it is a pseudoarthrosis. That is a congenital pseudoarthrosis of the tibia in a child. Now we may be asked about the how will you going to counsel the parents. This is extremely important, and your affective domain will become judged. Now the word round. Now word round basically, I'm giving the example. Like suppose there are 4 word round. In word one, there will be picture of station. This is a skeletal traction. Now there may be some second station, maybe some post-operative patient with some drain, some back drain or like that. Third will be the chest drain. There's maybe emergency situation, like the chest drain is given, some airway is given, some oxygen mask is given, some oxygen cylinder is also in the picture. So we'll be asked about those one. I will show the examples. And then fourth may be some conservative, like long leg plaster, the groin to plaster. So in each cases, we have even asked these common questions, like as you can see here, we identify the system first. Now all the systems are working well or not, you have to identify. If not, you have to spot the problem. And if the problem is spotted, then the corrective measures is asked from you. And lastly, the possible complications and the preventive measures. I will show you the examples. Now, 5F station, like suppose it's a station A, it is a first station is on radiograph. So in that case, you will be asked about the identify the radiograph. You have to describe the radiograph. You have to go the diagnosis. You can go for the differential diagnosis. Next is the investigation or confirmation of the management. Now the tips for this station is describe symmetrically. So I will show you how will go symmetrically, like A, B, C, D of the radiograph. Next is the pinpoint of the broad spectrum diagnosis. So if there is obviously it is 100% obvious, then you can go by the pinpoint. Otherwise, it is better to go by the broad spectrum diagnosis. Suppose that you are showing it is a malignant tumor. It is almost you are very much sure about the osteosarcoma, but it is better to go by the malignant tumor of a immature bone like that. I will go with explanation. Now then another station will be on instruments and implants. So instruments, we have to go by the nomenclature, parts with utility, how to hold it. It is sometimes it is given. Suppose some periosteum elevator is there. So we have to ask to hold. So you have to ask to hold it with your thumb on your thumb rest. That is the way to hold it. So how to hold it may be asked by the examiner. Now general use. General is already used. Now I'm giving the tips. What is the general use? I'm not going into detail of the instruments, but because I already took the class on the instruments. Because it is shortage of time, I will not go by the details. But general use is the A, B, C, O. That means almost all of the general instruments may be used in these 4 conditions, like amputation, A for amputation, B for the bone grafting, C for the chronic osteomyelitis, like in chronic osteomyelitis, which operation is done? That is the sequestectomy and saucerization. in which the C, in almost all of the general instruments is used. Lastly, the O for the osteosynthesis, that means the open abduction and internal fixation, where the most of the general instruments are used. Now the special use, suppose there's a periostem elevator. What is the special use of periostem elevator? That can be asked from you. What some modification of this periostem elevator, like this, some Cobb's periostem elevator, like that you can ask about. Now next is the sterilization. It is a universal questions. Now the implant. In any implant, we have to ask about the nomenclature. Next is parts with the utility. Next, the specific use of the steps, specific steps in operation. It is very important. Next is the technique. Suppose there is some calcar reamer. The calcar deforming reamer is given. Now, in that case, you have to ask in which step of joint replacement it is used. So you have to tell about it. And specific technique of using this. This is also important. Now, another important station is the orthotics and prosthetics. In orthotics and prosthetics, almost general questions is asked is the nomenclature. First is the nomenclature. I will show you how you will nomenclature the osteoorthotics and prosthetics. Next is parts with function. Next is how to wear it. Suppose it is the dynamic coccus plate. So in that case, so you have maybe asked to use it in your hand. So how to wear like this, we've asked about. Suppose there is some public harness is given. Now the question is, which strap of public harness is tied fast? There are several straps like the chest strap, like shoulder strap, and the lower limb strap. So in which strap should be used first, if we asked. Now indications and contraindications. Next is the limitation. So suppose that I'll show you what is the limitation, complications. Next is the guidelines and advice for it. It is extremely important. Suppose you are using the foot abduction orthosis, foot abduction orthosis for after correction of the CS of the DDH. So what should be your advice? Or just we have just after the corrective CTEV, we have used the foot abduction orthosis. So immediately after the just starting of this use foot abduction orthosis for the CTEV, you have to ask to wear it at least 23 hours of a day. So for first 3 weeks, first 3 months. After 3 months, for another 3 to 6 months, you have to wear for 14 to 16 hours per day. So this is the general guidelines you may be asked for about. Next, the prosthesis. So basically, you have to ask about the nomenclature. Suppose it's above knee prosthesis, that is or the below knee prosthesis, like that. Parts with function. It may be socket. It may be exoskeleton. Maybe in endoskeleton. It may be such foot or the Madura or the Jaipur foot. So we have to identify it. Next is the indication and the contraindication. Next is the complications and the guidelines and advice. Again, same thing can be asked for this. Next is the research. It is most important, and I will give for at least 5 to 10 minutes for this, because this is the new one. It is just included in this examination part. And in this research related, basically research should be related with your thesis. This is a fortunate thing. So beware about that. So we have to ask about which type of research you have done. There are different types of research. There are some variables are there: samples, formulation of the basic research questions, level of the evidence, and the indices of the assessment of the journal. It may be asked. Now, recent advances, this is extremely important. These are basically almost, they're almost universal. So you can remember this. So you may be asked about in recent advance treatment of recent advances on cartilage disease, like the autologous chondrocyte transplantation, mosaicplasty, gene therapy, new tribology of the prosthetic joints. Next, the bone graft substitutes. What are newer bone graft substitutes you can ask for? Microsurgical techniques, modular OT facilities, as also the sterilization. Now the operative. Now in operation, you may be asked about the pre-operative. You see, what are the, suppose one operation is used. Suppose there is what are the approaches of the hip? And you have started to tell about the Smith-Patterson approach. So how will you start with? What are the points to be mentioned? So always start with this. This pre-operative checkout is a must. It is first. Next is the anesthesia. Which type of anesthesia is it, regional or general, like that? Position of the patient is extremely important, and the limb, position of the limb. Next, the approach. Next, the incision. Now, the muscle interval, the nerve is in the interneural plane or not. We have to take that care of the vessels. And lastly, the specific technique. Now, it is sometimes you may be asked about, apart from this, what are the planning before operation? What are the prescription of implants? What are the surgical anatomy? You may be asked about. Now, what are the specific danger or complication out of this specific approach? So these are the questions may be asked apart from this. Now, another important station is the osteology. Basically, there are two types of bones you may get. There is either long or short bone, or the articulated hand or foot or pelvis. Long or short bone, like you have to hold it in, we have been asked about to hold it in anatomical position. This is most important. Next is the parts with attachment of the muscles. Vessels and nerves comes close to humerus. Suppose it is given in the example. Suppose humerus is given, and tell what are the nerves coming in close to the humerus, like the axillary nerve, the radial nerve in the posterior, also the lateral part, and the ulnar nerve also. So you have to tell about it. Next, the anatomical peculiarity. Like suppose the tibia is given, we have been asked about the anatomical peculiarity of the tibial plateau, medial tibial plateau and the lateral tibial plateau, like that. Next is the articulated hand, foot or pelvis, if you given that. Next, we have to ask about the parts with attachment, arches or lines. Next, suppose in the hands, there are some gillulus line, it may be asked about it. Now, articulation, yes, there are several articles. Suppose in the articulated foot, you may be asked about what are the articulations the calcaneum is made. Now, what are the movements are occurring, like that. Next is they have to tell about the anatomical alignment and anatomical position. Now the specimen, yes, specimen, that may be microscopic specimen, or there is some microscopic feature is given. The macroscopic feature is given like the malignant tumor, radial head, meniscus, sequestrum, the port spine. So you have to identify the parent bone, you have to identify the lesion, like the nature, malignant or benign, and location. Yes, if I'll show you an example. Next, the type, if there is sequestrum, this type of the sequestrum, cause, fate, or management. Then to the spine, you have to identify which part of the spine is it cervical spine, dorsal spine, or lumbar spine. We have to locate the disease. We have to know if there is an infective disease or neoplastic disease, and how much vertebra is involved. It may be asked about. Now the microscopic, there may be giant cell. This is a one picture of giant cell may be given. It may be tumor giant cell, or it may be Langerhans type of giant cell, like that. It may be bacilli, it may be acid bacilli, it may be asked about. Now malignant cells with osteoid, that is a picture of osteosarcoma, may be given in your picture in the PPT format. Now to identify it with explanation, you have to you may be asked about the cause and what is the management, like that. Now suppose this is the case, such 18-year-old boy presented with low back pain and painful left hip motions. Mind it is left hip motions, especially in the early morning for last 3 years. So you have to ask about the identify the gait. So can you see that this is sound side, this affected side is swinging like the pendulum, isn't it? So left side is problematic, and see the trunk is going on that way. So this is basically, it is a Trendelenburg gait. It is a Trendelenburg gait. Now mention two relevant inspectory finding may be asked. See the ASIS. You can, if you see the momentarily when he stands, ASIS is at a lower level, isn't it? Yes, it is a lower level. So it may be abduction deformity. That is how it is apparently lengthening. So that is one inspectory finding. There's another inspectory finding. If you may ask, see if there is abduction deformity. So there is an ASIS at a lower level, and there is a reflection deformity. There is abnormal space between the head and in the body and the bed. Now you may be asked about the two relevant palpatory finding also, like, so suppose there is a ASIS, it is one. Another is maybe if it is a low back pain and in the hip, that may be a case of ankylosing spondylitis. It may, we can tell about the chest expansion, like that. This is another case. This is an 80-year-old girl. You can see here, this 8-year-old girl. This is a girl. Is completing a breaker and fall on ground for last. You can see here. It is a ground for last 5 years, following the some injection in the left thigh, and which is taken for diarrhea in early childhood. So, what is the complete diagnosis? So, basically it is a habitual. You see, it is a habitual dislocation of patella in flexion. See, it is dislocating in every flexion of the knee. Why it is the explanation? It is dislocating in every flexion of the knee and is relocating in its normal position in extension. So it is a habitual dislocation of patella. Now you have to ask about the mentioned two pathologies, describe the two investigations, and mention the two standard surgical technique for correction. Now this is another specimen you can ask. So, so again, you can easily ask, it is identified. It is a large sequestrum. So to identify it is a long tubular sequestrum. How to identify? Because see, there is a serration on the one side, and if you see on the inner side, it is almost smooth. So the outer side is bathed by this granulation tissue, inner side is bathed by there is pus. So in which age it is common? Basically, it is large. So large sequestrum is commonly seen in the childhood because the periosteum is so thick, it is completely taken off, and this happens in the childhood. Now you have asked about the types, fate, diagnosis, and the management. Now this is another case. See, this is the patient. Patient is mentioned one relevant clinical complaint. Then this sort of deformity is completely corrected once the patient leaning forward. So what is that? Basically, it is a list. So list happened because of this prolapsed intervertebral disc. And what is the relevant clinical complaints? That may be low back pain with some radiation. That is radiation to one side. It may be either right or left depending on the position of the disc. So we have to identify it. Now identify the inspectory finding. Basically, it is a list you can see here. Now identify the clinical test. Basically, the test is the correction of is completely correctable with once the patient is leaning forward. So this is the basic difference between the list and the scoliosis, structural scoliosis. Now mention the common differential diagnosis with points to exclude. Basically, it is a scoliosis. Common diagnosis is the scoliosis, where the structural scoliosis it should not be corrected. Till another clinical test is there are Sobert test, Braggart's test, that is Fagerstrom's test. That all the tests can be done for increased sciatic tension. Mention when it becomes orthopedic surgical emergency. If it's a PIVD, orthopedic surgical emergency is only possible when there is a cauda equina syndrome. And the radiographs, see the radiograph, there's loss of lordosis. It is a straight line. So this is about the case. Now this is another this is a specimen, and we have asked about what are the preservative, the structure identification. So again, how to identify which component of the spine it is. It is a cervical, dorsal, and the lumbar. So especially it is see the first you see the disc space. It is a disc space. See it is a quadrilateral. So it may be either dorsal or the lumbar. And see the disc space. This is the disc space. This is the disc space. But where about the disc space here? To the two vertebra. This is the one vertebra and two vertebra. The two vertebrae, here it is almost three vertebrae involved. It is cut from midline. And this is this spinal cord. And see, these are the spine. Now, if the spines are going downwards, this is very slanted. So this is identified as a lumbar vertebra, whereas it is in a transverse manner. So it is a dorsal vertebra. So basically, so this upper part, it is horizontal. In the lower part, it is slanting one. So this is almost a dorsal lumbar junction. So where it is very much favorable site where this space is completely damaged. And see, it is enclosed on this spinal canal. So commonly it is a case of Carey spine. So pathology, basically it's a Carey spine affecting the dorsal lumbar junction. Now, how much vertebra is involved? That will depend on how we have to count the number of spine as also number of the vertebra. So this is the way to diagnosis. Now this is the case. What is the case? Is almost a neoplastic case, as you can see here. So how to identify the bone? We have to see the cross section. You have to cross section from above. If the cross section is triangular, so basically it may be a femur, or it may be a quadrangular in the upper part. It may be tibia. You see, it is seen almost in the lower part of the femur, where you see the articular surface, and there is a central expansile lesion. This is a central expansion lesion. See, it is cortical burst. Cortex is almost ballooned out, and inside it there's a severe fleshy mass. It is extended up to the joint. So basically it is a epiphyseal metaphyseal lesion where the cortex is ballooned out, and it is in a mature mode, as there is no physis is seen. So basically, is most commonly it is a giant cell tumor. So you can tell it is a benign tumor at the mature bone, which is commonly it is a giant cell tumor. Like the answer will be like that. So we have to identify the anatomy, then the pathology, pattern of destruction, and there is a diagnosis. Sometimes it is seen loculated, but loculi is not seen. Instead of there are some necrosis and hemorrhagic spots are already given. If there's some loculi, it is the classical feature of osteoclastoma. But if it is see it is highly fleshy one, so it is going to become, it may be going to become malignant. That is why it is completely taken out. That is the reason why it is completely taken. Otherwise, it may be treated by excision, curettage, and bone grafting or bone cementing, like that. Now, this is a word round. I'm not going to detail. In the last class, I already showed you that I'm going through the questions, like what is the upper extent, transverse, oblique. There are lower extent, which may be palmar side or the dorsal side. Why up to the proximal palmar crease? Why up to the not in the distal palmar crease? That is most important. If you go to the distal palmar crease, then we will hamper the MCP function. So if we go why up to the knuckle, because if you go further proximally, you can hamper the dorsal venous arch. This is most important. Next, the base of the thumb should be kept open or closed. Now, what would be the position of the wrist inside the plaster? This is most important. It is not more than 10 to 15 degree palmar flexed. Ulnar deviation, it will be very mild. Is 5 to 10 degree, not more than that. This is most important. Now, if the distal radial metaphyseal fracture involves the DRUJ, so if the distal radial metaphyseal fracture involves the DRUJ, what should be the modification? So that will be a sugar tongue cast, where there is some U cast is applied from this, along with this component, we have to give a U type of plaster slab. Plaster slab should be applied around the knee, around the elbow joint, like that, so that it will cover the superior radioulnar joint. This is the answer. Now it is another word round. There's a 25 years old treated with this due to the closed floating knee injury with altered sensorium for last 7 days. What is the exact site of insertion of the traction pin? See, this is the calcaneal traction pin. So it may be asked about what is the exact site of insertion. Which soft tissue complication will you expect from improper padding of the spin? That is the arch. You can see here the increased arch. That may be Pesky-Vaz deformity. Name any special knot. This is a clovich or barrel knot. You can tell that like that. Is the traction is working properly? Definitely not, because there is no bed and pulley. Now, which iatrogenic complications of the foot will be expected? Because there is a Pesky-Vaz deformity, maybe due to some damage of the medial calcaneal nerve. And how to dress the skeletal traction pin? It is open method of dressing. It may be used with a non-irritant, normal saline, and the antibiotic like Cifran eye drop. Now this is another the word round. Now see, this is the NRBM. This is a non-rebreathing mask. This is a valve mask ventilation. Maybe this is a non-rebreathing in a non-rebreathing mask. There are different questions may be asked. Just I'm going through the questions because of the shortage of time. Like what are the technique? This will be a 3-finger technique of mask holding over the patient's mouth. How much oxygen? Because in the air there are 21% oxygen, but we want to give more oxygen. We can use this face mask, and through the face mask we can give 60% of oxygen, maximum 60% of oxygen. But we can increase with the help of the flow meter till we maintain the 94% SpO2 with the help of the oximeter. So other options may be oxygen hood or oxygen cage. Especially it is used for the children for covering up. They got much more coverage over the mouth. Now, if you want to give more oxygen, like up to 70% oxygen, we have to use the nasal cannula or nasotracheal tube. And again, if you want to give much more oxygen, suppose there is a sudden cardiac arrest, we can want to give 100% oxygen. In that case, we have to do the endotracheal tube. But mind it, 100% oxygen cannot be given for long period, at least for more hours or 2 to 3 hours. If you give much more time, so that will cause the almost collapse of the lung. So 100% that can be given momentarily within a few minutes, so that oxygenation is corrected. Then we go by the say 60 to 70%. Now, which sort of oxygen? It may be moist or dry oxygen. In most of the cases, we get to the moist oxygen, but beware, you have to change the water. Basically, it will be a sterile water. That sterile water should be changed every 24 hours. Otherwise, there will be high chance of mucormycosis. Now, there are several other there are modifications like high flow nasal oxygenation may be asked, BiPAP or the CPAP. So, and the oxygen toxicity. So, how to do the oxygen toxicity? It may be asked about the questions. Now, the chest drain. Now, this sort of picture, if we can be visualized, you can ask. Now, what are the indications? Suppose it is a pneumothorax or the multiple rib injuries with pneumothorax or hemothorax, you have to use this. Now, what is the site? This is the SEP triangle. SEP triangle is this one. This is the lateral border of the pectoralis. This is the anterior border of the latissimus dorsi, and this is the fifth intercostal space. And we have to go by the just upper border of the fifth rib in the same line of the nipple, and the direction should be towards the apex. This is the technique. They have to ask about the care of the wound. Which sort of special stitch? This is the purse string stitch can be used on this. It will be almost it be sealed. We have to seal so there will be no ear leak. This is most important point for wound care. Now, when to remove? When the oxygen is almost completed, movement of the this movement of the water and the blood will become completely seized. And if you see this sort of radiograph, this is the before, this is radiograph of before application, this is after application. So see, this is almost, it is completely, lung is inflated. Then we can remove it. And what is the advice during removing? Ask the patient to hold the breath in full inspiration and make a sudden we have to cut it and sudden take it out within moments. This is the way to remove it. Now, what are the wounds? This I'm giving importance on the ward round, because there are different types of wounds. How to classify, how to differentiate between the surgical, traumatic, infective, non-infected wounds, like that. So the special dressing for specific wounds. Just I'm going to make your life very easier, because traumatic wound, it is frequently asked. What are the different types of traumatic wounds? Now, there are two types of traumatic wounds, maybe non-infected and infected. So infected, always we have to start with the surgical debridement. So if it is after surgical debridement, it may be discharged. Yes, then we have to go by the vac application. No, then we have to start with the dressing with the cleansing agent. Cleansing agent. What are the cleansing agent? There are three types of cleansing agent, like disinfectant, antiseptic, and the antibiotic. What are the different definitions and the difference you may be asked about? Now, the non-infected wound, it may be, we have to see whether it is slough present or not. If there is no slough, we have to start with the dressing with the cleansing agent. If there is slough, yes, we have to start with the cleansing agent. But remember, we have to use the chemical dislougher. What are the chemical dislougher? I will show you. Now, if the slough is associated with some edema, we can start with the cleansing agent application, but we have to add with this alginate, hydrocolloid, or the collagen granules of the sheet. Otherwise, if these all complications are not present, after the application of the cleansing agent, you have to use some agents which stimulate the production of the granulation tissue. Now, what are those? Now, cleansing agent, I've already told, it may be normal saline, or it may be pre-boiled water, or it may be hydrogen peroxide, which is also hemostatic. By increasing temperature, that stimulates the extrinsic pathway of blood coagulation. Now, disinfectant, it may be Savlon or Dettol. Antiseptic is a low concentration betadine, chlorhexidine, tincture benzoin, surgical speed, 70% alcohol is there. Now, antibiotics is high dose betadine, chlorhexidine, silver ion, quirion, nascent oxygen producers like hydrogen peroxide, oxoferin, and topical antibiotic. Now, what are the chemical dislougher? There is a nascent chlorine producer. This is a usol solution or the vinegar. And the granulation tissue degenerator, the silver ion, megahill, placenta extract, collagen granules, and the collagen sheet. Now, what are the different types of dressing? It may be open dressing or the closed dressing. For the open dressing, you can use the chemotherapeutic agent. Already I've shown you there are different types of chemotherapeutic agent. In closed dressing, we have to cover the wound, and there are three types of covering. So the inner covering, intermediate, and the outer. Inner contact layer may be inert or the active. Inert, that it may be cotton gauze, paraffin gauze. Active may be that is paraffin gauze with antibiotic, alginate, or the hydrocolloid. Intermediate absorption that always should be inert. It may be cotton roll, Gamgee roll, or the cotton roller bandage. Outer compression that may be cotton roller bandage, elastic crepe bandage, adhesive, or adhesive, and the different types of adhesive like cotton cloth, paper, and the synthetic silky. Now, these are again real case. So how to exclude the hip flexion? See, this is a quadruple deformity. This is a flexion, abduction, the external rotation, and the posterior subluxation. Now, how to exclude the hip flexion deformity? There may be possibility of associated hip flexion deformity is also there. So see, this is the bedside Thomas test. Now, you may be asked about how to assess the flexion deformity. There's a bilateral hip flexion. You may be asked about to show it. This is a psychomotor domain. Now, the radiograph is always A, B, C, D. What is that? So A for adequacy, B for body and the course. And adequacy maybe it will be alignment. There is rule of two. All the long bone should contain the joint proximal and the joint distal, and also the AP and lateral view. Body is 3 points and the 4 densities, and we must have some date to see whether it is a fresh X-ray or the old X-ray. And the patient, you have to see the age, background, and the site. The basics, the rule of two, then we rule of 2 views, 2 joints, 2 sides, occasions, 2 size, and also to special view. 3 points, that is, we have to see the patient, next the soft tissue and the bone, the 4 densities. Now, for the trauma, we have to see there's some displacement. The class, I'm not going into detail. We have to see the linear displacement. We have to see the angular displacement as also the rotational displacement. And for the joint, we have to see whether it is subluxated or dislocated, or it may be normal or pathological like that. So this is the, so there are different, this is the angulation. You can see here, this is a different angulation. And see, this is the tilt. Tilt is basically the determination of the articular surface, facing of the articular surface. Basically, there are both an angulatory management. Now, there are different lines and angles. I'm not going into detail. You may be asked about Bowman's angle, metaphysical diaphysial angle. Now, radiography of the disease, again, A, B, C, D, E, F. A for adequacy, age, and angle. B for the bone, we have to go from outside inwards, like the soft tissue, periosteum, the next, the cortex, and the medulla, and then the joints. And C for the central or eccentric lesion, D for the density, sclerotic, lytic, mixed, E for expansile or not, and F for the fracture dislocation like that. So this is eccentric expansile lesion is a metaphysical diaphysial. So you can describe like that. And there are several specific radiograph you may be asked about it, like the pelvis radiograph. Now, orthosis, yes, the classification is very simple. There is the joint encompassed by the orthosis that determines this classification. Like the lower limb, there is a foot orthosis, ankle foot orthosis, where the ankle, the orthosis encompasses both the ankle joint and the foot joint. So this is the ankle foot orthosis. If it's only the knee joint, this is a knee orthosis, like the hinge knee orthosis or CAFO like that. This is simple. Cervical orthosis, cervical thoracic orthosis, there is lumbosacral orthosis, like that. Joint encompassed by it. I'll give in the simple indications. The weakness, what are the indications of using the orthosis? It may be weakness, UMN, LMN, the insensible, loss of structural integrity, or the deformity. It may be flexible, dynamic, or rigid. So you have to ask about this. Which strap should be used first? We have to use first the chest, then the shoulder, lastly the lower limb. Similarly, this is the ankle foot orthosis. There are some limitations because that will not provide the ankle motion. That is why they are given the hinge. Now I'm very much concerned is the last part is the research. It is extremely important. Basically, there are 2 types of research: is the quantitative and the qualitative research. And for the orthopedics, we are concentrating on the quantitative research. It may be experimental and the quasi-experimental. Basically, in experimental, it consists of the manipulation, the randomization, and control. All three will be there. In quasi-experimental, manipulation will be always there. That means we are giving some manipulation, but either randomization is absent, or this control is absent, or both may be absent. So that is the quasi-experimental study. Or maybe non-experimental study, like descriptive study, like correlational study, development, and epidemiological study. Others that we are not concerned, these are not required in orthopedics. Now, what are the tools of the research? We have to understand the basic research problem. We have to understand first the basic research problem. For that, we have to start with the research topic. We have to look at the review literature. Then from the review literature, we have to identify the knowledge gap. And from the knowledge gap, we have to identify the need of our problem, and we have to formulate our final statement. Now, for that research, we require some variables like independent variables and the dependent variables. The independent variables is one which is manipulated. That means suppose we are giving some medications for reduction of the blood pressure. So that medication is basically, it is our independent, because we can increase the dose of medication. And the dependent is the variables is the actual blood pressure. So this is the dependent one. Now there are several other variables like the research variables. Research variables means we are want to see whether some students are very brilliant or not. So some brilliancy, it cannot be measured by its numerical. So these are the research variables. Or demographic variables means age, sex, like that. And there are some other variables not important. Now we require some population. Population is required by the probability. Probability, that means we can take out can select the population with the help of some some lottery system. Like, so that is how it is known as the random sampling. Or it may be some non-probability or purposive by indication, contraindication, by specific purpose we can impose for collection of our population. So this is the two types of population. Now there are some assumption on the hypothesis. Hypothesis is extremely important. That I want to know, suppose my technique is better. That is the hypothesis. So that hypothesis can be tested. Assumption cannot be tested. So, and then null hypothesis is one that indicates that my hypothesis is wrong. That is the null hypothesis. And research hypothesis means I want to prove my test, that my test is superior. That is a research hypothesis. So this is the difference between the null and the research hypothesis. Now, evaluation of research, then what are the tools? How will you collect? How will you measure our research? With the help of the interview, with the help of the questionings. There are different like VAS code. There is a visual analog scale. There's observation, rating scale. There are the different rates or scale like that. Biophysiological methods or others like projection, Q-sorts, and Pignets. And the way of statistical analysis, there are two types: descriptive statistics or the inferential statistics. Descriptive statistics means once the data is already we got that, we can put on the table, we can pie diagram, histogram like that, and we have to measure the central tendency. That is, what is the common? Suppose there are 10 students of different age group. So what is the common age group among the 10 students? So this is known as the central tendency. That can be measured with the help of the mean, median, mode, standard deviation, normal probability curve, correlation. So we can compare between the two variables. So we can compare between the two persons, whether who one is good or who one is bad. So this is the correlation and component, and that can be done with the help of the R value. There are different methods. Inferential statistics is basically what we have got the value, we have to how much it is significant. That means this is known as the p value, and it is asked in the last in one examination is what is p value, and p value is measured at the degree of freedom. I'm going to the next slide. Next, and there's a test of significance. How much my result is significant? This is the test of significance. So basically, this is most important slide. Please remember this. So what is p value? P-value is basically the probability of rejecting null hypothesis when it is true. That means that means I know I can accept the limit is either 1%. My error is limited either 1% or 10%. That means if I perform 100 cases, of which I can accept at least 1 case may be wrong or 5 cases may be wrong. So that is the level of significance which is determined by this p-value. This is the probability value. Basically, it is known as the p-value. And the maximum acceptable limit is 0.01 and 0.05. So if we estimate the value, there is some table that is known as the T table. So from the T table, we have to compare my value with that value. If my value is less than that 5%, that means I am correct. My value is significant. So that is known as the p-value. So if my estimated value is more than that is already t value, it is already t chart. So it means my finding is wrong. So that is the most important point. And the degree of freedom is that is the number of values that can vary. That how many numbers we are using. For paired, see, there are some paired test of significance can be done with the help of the two parameters. That is a parametric test or the non-parametric test. Basically, there are two types of data. There is a continuous data or a discrete data. Continuous data means some age. Suppose age is 10 years. It is a continuous data. And another data is that cannot be numbered, like male, female. Male cannot be fraction. Female cannot be fraction. So these are known as the discrete data. So if we work with these numbers, these are the continuous data, the method of estimation of the significance is known as the parametric test, where we can use the t-test, z-test, or the ANOVA test. So t-test is basically the two types of t-test, like paired test or the unpaired t-test. If both the groups are same, suppose we are measuring the blood pressure among the two groups which are same, like among the doctors we are measuring the blood pressure among the faculties and the students. Both are doctors. So these are the paired group. So in that paired group, we can measure the t-test. And this degree of freedom, that means for the paired t-test is n-1. This is known as. Or the unpaired t-test, that means we are measuring the blood pressure between doctors and the sisters. There are both a different group. So for the different group, if we take the result, they think that we have to do the unpaired t-test. This is known as t-test. But the number of candidates, if it is more than 30, we can do the z-test. Or if there is a multiple number of experimental group and multiple number of control group, in that case we have to go by the ANOVA test. This is the basic idea. Or if there is some discrete data, that means male, female, good or bad. So this cannot be make fraction. So these are known as the discrete data. If we work with this discrete data, then there are some other tests can be done, like the chi-square test, Mann-Whitney, Fisher extract, like this. Now plagiarism, this is the last one. Plagiarism, basically it is the use of the others' published and unpublished ideas or words without attribution or permission and presenting them as a new or original. So this is known as the plagiarism. Basically, there are different types of plagiarism. There is a verbatism, which is known as the simple copy and paste. There is a mosaic or patchwork. There is each word is not copied, but it involves some mixing your own words along with some other words. So basically, it is known as the mosaic or patchwork. Paraphrasing is basically if one rewrites any part or paragraph in their own words. There is not a paraphrasing. Self-plagiarism is the publication of one's own data. Author A, suppose, published one article in 2017, and the same article is again publishing in 2020. So that is the self-plagiarism. Another cyber plagiarism is copying or downloading in part, not whole, but some part of the articles, in the introduction part or in the discussion part, like that. So this is our image plagiarism. So this is just only image is taken. Our unintentional plagiarism, if it occurs when the writer incorrectly quotes and or incorrectly cites the source. So how to diagnose? There are some sites are there, and there are some avoid some. Last one, this is the import factor of a journal. This is one asked in the last examination. Basically, it is given this is how total number of times its article was cited during the last 2 previous years, followed divided by total number of citable articles. Suppose in the last 2 years, there are International Journal of Orthopaedics, there are 20 journals, 20 articles is published, of which some other authors, they have cited, there are six citations. So 6 by 20, it is the impact factor for last 2 years. This is always it is given in last 2 years. So if you ask what is the impact factor of this year, one cannot tell, because that will tell the value of the last last 3 years value. This is the most important. This is the impact factor. The total number of times the articles were cited by other authors divided by total number of citable articles it is published in last 2 years. This is basically the impact factor. So this is the one. Thank you. I think there are several questions, and we'll ask about the questions.
Okay, thank you, Dr. Pal. I think we will go on to the questions. I think there's a lot of material covered there, and I'm sure there will be a lot of questions. So I would hand over to Dr. Janki and the postgraduate students to ask their questions.
So I think most of the things you have covered, sir. if you can focus on what is the changes in the practical examination after the emergence of this pandemic.
Yes, yes. Basically, the examination is going part in most of the virtual component. So, of which for most major part is in the OSCE. Now, previously, it is OSCE may be given in either 20 OSCE or 25 OSCE. And it will be given in the total number format, total time format. It should be either 2 hours. So, we have within 2 hours, we have to complete the OSCE. After the completion of the OSCE, so we have to go by the case scenario. In case scenario, there are either I already told there are two type of case scenario. One is the virtual case scenario, another is the real case scenario. In some centers, they may provide the two real case scenario, or in some center they will provide the two virtual case scenario. So in every case, in every condition, so there will be some specific information is already given. Suppose what is the concise history and the background, and the candidate is asked about the probable diagnosis, differential diagnosis, what are the tests to be done. If any history is missing, the candidate has also scope may be given to the scope. Either do you want any specific history from the examiner or not, like that. Lastly, if it's a real case, so you will be always asked to show some test in a hand-on test. And that I already prescribed that, I already advised that always start with the consent, then the position, and also understanding. You have to make a rapport. You have to make the subject, make the patient understand that I'm going to make a test, so that you have to cooperate. So this is the three thing is mandatory. After that, we have to start the test. And lastly, the viva voce. I already told the word round and the viva voce.
So, Dr. Vinas has asked about how to manage time in OSCE examination.
Yes, OSCE, for that we have to make a practice. It is extremely practice, and because this is the extremely new one, and you have to attempt everything, because there is so far I remember there is no negative marking. So we have to mark everything. So if it is wrong, nothing matter. You have to go for you have to choose which one is the easiest one. There are 4 questions, so you have to go by the easiest one. So you mark it fast, and then you have to go by this the next relatively tough questions, like that.
So can there be a descriptive answer question in OSCE? This is the second one what Dr. Vinas has asked.
No. There will be no descriptive answer. There will be to the point answer. Always to the point answer is asked. Either 1 line or 2 line, like that. There is no descriptive question like India.
So when you have a case in the exam, sir, the one confusion which usually orthopedic student has is that when approaching the patient, we should approach it from the right side or from the affected side, because from the beginning in the medical school it is we have taught that to start from the right side. So is it applicable for orthopedics?
It is not strictly applied for the orthopedicians. I think Professor John Mukhopadhyay also will support me. Actually, this basically is not strictly followed by the orthopedicians. The orthopedicians are very much free enough to go on the other side also to take about the exact pathology.
Yeah, so it depends on what you're doing. If it's a right hip, obviously you will do it on the right side. But if it's a left hip, you can examine the right side from the right, but you must always examine that particular hip from the same side. Otherwise, you're going to make mistakes.
Exactly.
Similarly, so even with the knee, if you're trying to do something like a Latchman's, it's better to be doing it from the side that the...
Absolutely.
So you have mentioned in your lecture about the chance of mucormycosis with the moist heat. So is it that moist oxygen? So do we prefer dry oxygen for that one, sir?
Yes, that is a very, very important and very practical questions. I'm very fortunate you have asked it, because in this traditional teaching is always use some moist oxygen. But the problem is moist oxygen, that what sort of moisture you added, how much moisture you are added, nobody knows. And which sort of liquid you are using. Basically, it should be a sterile water. Sterility is almost, it is a unpractical in our developing country. So what we are using, basically is a tap water, or sometimes it is a very dirty water, or the water is maybe changed 3 or 4 days. So it is very much harmful for the patients. And this is now, it is coming in a big way, like a mucormycosis in the COVID states. Now, so that is why it is now recommended, if we use some water, this should be a sterile water, or it is a pre-boiled cool water, and that should be changed every 24 hours. Otherwise, you can use some moist oxygen, but dry oxygen, but you have to check the well hydration of the patient. If the patient is well hydrated enough, so there is no harm of giving the oxygen. That we have to actually treat the cause of oxygenation. That is most important.
Yeah, so apart from the water or the fluid that you use, it's all the parts that also need to be clean. Okay, so a lot of the mucormycosis is related to contamination of the connections, the tubes, which are often not changed many times. Okay, so especially in so your tube coming from the oxygen, if you're using a cylinder, or directly from the supply in the hospitals, those tubes need to be cleaned properly, etc. Because or they have to reuse sort of sterile tubes, because a lot of the contaminants are either in the water or in the parts used in the ventilation or the oxygenation. Okay. And of course, that is not the only factor. There are other factors like use of steroids, diabetes,
Exactly,
compromise, etc. So it's
internal environment should be treated for the prevention of this.
So I think we should ready for the question for the COVID also during even in orthopedic practical, sir.
Yes, sir.
Is
That
it-
is how. That's why I have kept that is oxygen supply. The different techniques are like that. This is
so you could be asked about what precautions you take. You won't be asked about COVID per se, but how would you counsel patients? How would you avoid? What would you do if a patient turns out COVID positive? Which cases would you do? Which would you delay, etc.? All those things can be asked. Yeah.
exactly. What is the protocol of doing orthopedic surgery in COVID scenario? This is maybe asked. So this answer is, if there is an emergency situation, so we have to do the operations taking all the precautions, like with the help of the PPE, everything, face mask, everything. But if it can be avoided or delayed. So in that case, suppose it is a patient becomes COVID positive. So in that case, we can do some damage control orthopedics, and we have to wait till the scenario is over. Now the scenario is almost 10 days. It is 10 days is a cutoff time. After 10 days, either it will be better if you do a rapid test. Now rapid kit is coming in a very good situation. So if it is negative, then can safely do the surgery.
So I think now, especially with the Omicron, the rapid antigen test is apparently almost as
Exactly.
this thing, but you can't be sure. So, okay, I think that's, we're already on to 8 o'clock, so we should call it a day. Thank you very much, Professor Pal, as usual, for spending so much time on picking out all the important things and covering so much material. It's amazing. Thank you very much. And till next week, bye, everybody. Bye.
Thank you.
Well soon. Okay.
Be safe.
You're already so well. Okay, bye.